Thank you for joining today's webinar. Dr. Lakshmi Srivaths will now begin the program. Doctor?
Good afternoon, everyone. Welcome to today's program, a case conversation on hormonal therapies in females with blood disorders, thrombophilia, thrombosis, hemoglobinopathies, and anemias. This article we're going to discuss today was published in April 2023 in the journal Research and Practice in Thrombosis and Hemostasis and was identified as a top 10 article by RPTH for 2023. So to begin the presentation, I'm going to introduce the faculty. I am Lakshmi Srivaths, professor in the Department of Pediatrics, Division of Hematology at University of Texas Health Science Center and McGovern Medical College, and Gulf States Hemophilia and Thrombophilia Center at Houston, Texas. My area of expertise is in the field of pediatric hemostasis and thrombosis and anemias. And I have served as a co-director for Young Women's Hemostasis and Thrombosis Program at Baylor College of Medicine, and currently the director of Pediatric Thrombosis Clinic at Gulf States Hemophilia and Thrombophilia Center. I also serve as the current chair of the For Women and Girls with Blood Disorders Learning Action Network, and also medical advisor for the Foundation for Women and Girls with Blood Disorders. I will be moderating the case conversation today. I'm joined by two of my excellent co-authors and fellow WGBD LAN members here, Dr. Maureen Baldwin and Dr. Bethany Samuelson Bannow. Dr. Baldwin will be presenting today, is an associate professor of obstetrics and gynecology at Oregon Health and Science University in Portland, Oregon. She has a practice-focused designation in pediatric and adolescent gynecology and is a co-director of an interdisciplinary hematology and gynecology adolescent clinic called Spots, Dots, and Clots, which treats teens with heavy menstrual bleeding and clotting disorders. Dr. Baldwin serves as a medical advisor for the NBDF and also the Foundation for Women and Girls with Blood Disorders. Her research has focused on hormonal management of menstruation, pregnancy loss, abortion safety, system approaches to contraceptive access, and also teaching with simulation. Next is our presenter, Dr. Bannow. She is an associate professor in the Division of Hematology and Medical Oncology at Oregon Health and Science University. She specializes in caring for menstruating and pregnant adults with blood disorders. Her primary clinical focus is the treatment of patients with bleeding disorders or thrombosis, and she has a particular interest in the impact of these disorders and treatments on reproductive health. She currently serves as a medical advisor for the Foundation for Women and Girls with Blood Disorders and is also the co-chair for the Thrombosis Subcommittee, WGBD Learning Action Network. Now, about the foundation. So we have been invited to present this program to you all today by the Foundation for Women and Girls with Blood Disorders. The Foundation's mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. With this, the Foundation aims to provide education to healthcare professionals on medical consequences and unique issues for women and girls with blood disorders. Next slide, please. Since its inception, the Foundation has focused on realizing its vision through these objectives, as you see displayed here. Before we start the program, here are a few housekeeping rules. To ensure the best sound quality during our program, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with our faculty at the end of the program. You can submit your questions during or at the end of the presentation via the chat box in your control panel on the right-hand side of your screen, and we will address them during the Q&A session at the end. The next few slides will detail our accreditation process. In support of improving patient care, this activity has been planned and implemented by CineMed and the Foundation for Women and Girls with Blood Disorders. Continuing education credits will be provided and a follow-up email will be sent to all the attendees explaining how to obtain your 1-hour CME or CE credits for today's program after its conclusion. And this activity is being provided independent of industry support. Here are the learning objectives for today's presentation. The learning objectives are to describe the dosing and formulations of hormonal therapies, to discuss the estimates of thrombosis risk based on contraceptive and menopausal dosing of hormonal therapies, and to review thrombosis risk with gender-affirming hormone therapy and menstrual management. Here are the disclosures for today's presentation. All provider employees in control of content have indicated that they have no relevant financial relationships to disclose, and speakers with financial relationships to disclose are noted here. So all our attendees, as I mentioned earlier, will receive an email about how to claim your 1 hour credit, and the accreditation overview is also available as a handout. We'll now move on to the polling questions before we begin the presentation. So we want to do this quick poll to see how many people are joining us today, and also to assess your current knowledge of this topic. So please take a moment to answer the poll questions on your screen. The first question is, please tell us how many of you are joining today for this conversation, whether you're watching by yourself, you have one other person, 2 others joining you, or 3 or more people. We can go to the next question. Next question is, which route of hormonal administration is associated with the highest risk of venous thromboembolism? Please select one of the options: transdermal, vaginal, sublingual, or oral. Next question. For which high-risk medical condition is estrogen not contraindicated? Please select one. Is it chronic hypertension, or greater than 45 years of age, prior history of venous thromboembolism, or severe cirrhosis? Next question. What does Category 2 mean in the US CDC medical eligibility criteria? Does it mean that the use of estrogen, to use estrogen if anticoagulated, to use estrogen in all situations, or use estrogen since benefit outweighs risks, or use estrogen only if anticoagulated? Next question. How do synthetic estrogens potentiate thrombosis? Probably due to upregulation of hepatic enzymes, or probably due to CYP450 drug interactions, or probably due to genetic polymorphisms, or probably due to binding to progestin receptors. Next question. This is the last question in this polling. The question is, which medical society suggests use of transdermal estrogen for their population, especially in high-risk health conditions? Is it the World Professional Association of Transgender Health, the WPATH, or the United States Centers for Disease Control, USCDC, or the North American Menopause Society, NAMS, or the Society of Family Planning, SFP? And this will be your last question. All right, thank you all for your participation. We will be asking the same questions again at the end of the presentation and share the correct answers at that time. At this point, I will now turn the slides over to Dr. Maureen Baldwin for her presentation.
Thank you, Lakshmi. So today I'm going to be speaking about indications for hormone therapies, hormone types and dosing, and mechanism of action of hormone related to thrombosis, or at least what we believe to be the case for that. risk versus benefits, and how to start on the decision making for whether to use a specific medication in certain situations, and then considerations for use in high-risk conditions. So first, indications for hormone therapies. I think a lot of times we think about hormone therapies in relation to contraception, or at least we use the word contraception or birth control when we're talking about hormone therapies. But there are many, many conditions for which we have good evidence for benefit for use of hormone therapies. And I'm talking about specifically gonadal steroid therapies. And so a lot of us in our group use them for heavy menstrual bleeding, menstrual regulation, for suppression of pelvic pain, for PMDD, for endometriosis, ovarian cysts, PCOS, dysmenorrhea, and then in fertility management, ovarian hyperstimulation. We also use hormone therapies in gender affirmation, and as well as in contraception. And then additionally in perimenopause and menopause, we'll use a different type of hormone therapies, often for vasomotor symptoms or genitourinary syndrome of menopause. So many, many conditions out there for which different applications of hormone therapies are really helpful and are given in different doses and in different delivery systems. So I'm going to just overview some of the hormone types and dosing to really think about how we're going to describe the different medications. So we often break the gonadal steroid hormones down into estrogens and progestins. Progestogens being the umbrella term that includes progesterone, which is the natural form of progesterone, and then progestins, which is synthetic forms. And then estrogens, which we'll go through, have some various types as well. But these are the general terms, and you'll hear us mostly use the term progestin. Most progestogens out there are synthetic. So when we think about the different types, we want to think about whether we're whether the patient's using combined versus monotherapy, and sometimes these are combined into the same product. Such as the combi patch in perimenopausal hormone therapy, where the patch has both estrogen and progestin in it, or in the contraceptive patch, versus someone taking an oral estradiol pill, an estrogen pill, and then also taking an oral progesterone. So there are different ways we can use these medications. And then we'll think about whether they're synthetic versus endogenous. And the main difference being that synthetic drugs have a slower metabolism. And so they are essentially more potent, they circulate longer, and they have different metabolic byproducts. We want to think about bioavailability. So if somebody has very high sex hormone binding globulin, their bioavailability of different estrogens may be different, for example, and that's very individual from person to person and not something that we test for, but can definitely impact the medication. Also, we want to think about whether they have a full gut. So somebody, for example, who's had a malabsorptive gastric bypass surgery may not absorb oral medications in the same way. Their bioavailability of oral medications in this family is going to be a little bit different. We think about the schedule, so whether the medication is being delivered in a cyclic fashion versus a continuous fashion, or an extended fashion, meaning that they may have hormone-free intervals every once in a while for different reasons, or whether they take it twice a day versus once a day, for example. And then delivery systems, delivery being whether it's transdermal, oral, sublingual, topical, or intravaginal, all the different ways that we provide absorption. And then drug interactions can significantly affect the dose, and those can be through, for example, anti-epileptic drugs, which have a bidirectional impact, meaning that through usually the CYP450 hepatic enzymes, both the anti-epileptic and the hormone, typically the estrogen, but also the progestin as well, will be metabolized more quickly, and both of those will result in lower drug levels for both medications. And then we also think about sometimes actually some genetic polymorphisms that might result in different metabolism of drugs. And then we want to think about what effect the medication is having. So whether it's binding to the progestin receptor or the estrogen receptor, or whether they're potentiating each other. And then whether they have endogenous gonadal status, so whether there are ovaries present or not, and how much endogenous hormone is being produced, whether that's normal or not. For example, in the setting of Turner syndrome, that might be a much lower level, or in PCOS, estrogen levels may be low or high, and androgen levels may be high. So these are things that we don't typically test for, but we want to just sort of take into account when we think about the effect of the medication. So there are many different synthetic estrogens out there. There are more coming onto the market now that you may have heard of. So here is just some pictures of the structure chemically of them. We're not going to be going into biochemistry here, but just demonstrating that they're different drugs. They're different medications. They bind to receptors differently. Mestranol, number one, is a very older estrogen, which is very potent, did have very slow metabolism, and was most associated with more VTE. 17-beta estradiol, number two, is the more natural form of estrogen, and it can also be synthesized, but it's a much more simple chemical structure. And estradiol valerate, number three, is another synthetic estrogen that is present in one specific pill, the only oral pill that's combined, by the way, for contraception that has indication for heavy menstrual bleeding. And then number four, ethinyl estradiol, which is in most contraceptives. So if we break down estrogens, we can kind of think about them in three categories. The endogenous or natural estrogens, these are the ones that are found circulating in someone with ovaries. So that's estradiol, estrone, estriol, estretol, which is only in fetal ovaries. And these can sometimes be also synthesized. And so estradiol can be synthesized, so can estretol. And then conjugated estrogen, which contains some natural estrogen and some synthetic, and conjugated equine estrogen, which contains some equine estrogen as well as some synthetic in a combination product. And then in ones that are entirely exogenous or synthetic, which are ethinyl estradiol and estradiol valerate, for examples. The different types of estrogen have different so-called estrogenicity. To the right of this path, I guess, we would have something like ethinyl estradiol greater than 50 micrograms. So if you have somebody who's got a 30 microgram containing combined contraceptive pill and they're taking it more than once a day, then they would be at the very highest level of estrogenicity. And to the left of this pathway, you might have levonorgestrel or norgestrel. Levonorgestrel is present in the hormonal IUDs as a monotherapy, and norgestrel is the component of progestin in the new over-the-counter progestin pill called O-pill brand name. And they have very low estrogenicity, in fact, almost none, because they do not bind to the estrogen receptor. And then in the middle, you might have other forms of estrogens. More generally, the ones that are more synthetic are going to be more estrogenic, and the ones that are more quote unquote natural are going to have less estrogenicity, mostly because they have faster metabolism. And so ethinyl estradiol to the right is the most potent estrogen we have because it has very high receptor affinity to the estrogen receptor and slower metabolism, slower metabolic breakdown. Progestins are mostly derived from one synthetic family called 19-nortestosterone. And so many of the progestins out there, the many that we see in combination products, have names that make it sound like there's a lot in the whole family, but they are really all derived from the same parent, so to speak. With the exception of number four here, drospirenone, which is slightly different from the, it's still a 19-nortestosterone progestin, but it has slightly different characteristics. And then medroxyprogesterone, which is more similar to natural progesterone, which is in number 6 here. And if we think about the way progestins or progestogens are categorized, we might have a very long list here, and I abbreviated it for simplicity. But on the left, we have synthetic progestins. So those are the 19-nortestosterone derived. So that's desogestrel, norethindrone, norethisterone, norindronil, gestadine. There's many out there. Progesterone derived, that would be like medroxyprogesterone. Spironolactone derived, that's drospirenone. And then mass-produced endogenous progesterone can be mass-produced, and so that's like Prometrium would be a brand name progesterone, and endogenous, which is just progesterone. And I think it's important to note that if you look at a product, for example, a combination birth control package, you might notice that some medications in this family might have a concentration or in the product of something like 0.2 micrograms versus 4 milligrams or 5 milligrams. And the reason for the difference is really just due to molecular size. They're dosed based on the ability to suppress ovulation and provide contraception in the contraceptive products. And so the doses are going to be vastly different. So let's talk about what we know about the mechanism of action for increasing the risk of thrombosis in this family. So ethinyl estradiol, the most estrogenic estrogen we have out there, is very potent, mainly because it's very long acting and because the metabolites continue circulating with hepatic metabolism. And so because they're continuing to circulate prior to complete metabolism, they our hypothesis is that they drive hepatic enzyme activation and therefore become more thrombotic that route. Other types of estrogen metabolize much more quickly into the natural estrogen breakdown. Estrogen binds specifically to the estrogen receptor, so and that's intracellular. And there are estrogen receptors in many end organs, in tissues, in brain, in the liver, and then when they bind, they take a while to result in downstream transcription and translation, and therefore result in the effect and changes after taking them. So this is why after taking a new medication, such as, for example, a combination pill to help stop acute heavy menstrual bleeding, it will always take 2 to 3 days for the action to take effect due to downstream regulation. Progestins, on the other hand, do not bind to the estrogen receptor. So here's a table from an old paper just sort of outlining the estrogen receptor activity that is observed with a few of the different 19-ortestosterone progestins. So for example, norethindrone, which used to be called norethisterone, on the top there has 0 binding to the estrogen receptor. And so when used in monotherapy, it does not affect the estrogen receptor. However, when used in combination therapy, progestins do potentiate estrogens in their binding to the estrogen receptor. So in combination therapy, there's slightly more potentiation than seen in monotherapy with progestins. It's important to note that we don't use estrogen by itself when there is a uterus. We need to always use a progestin with the estrogen so that we can reduce the risk of thickening of the endometrial lining and resulting in a higher risk for endometrial cancer. So in somebody who is taking estrogen vaginally, that risk is much lower. And so in postmenopausal therapy, we might use an estrogen that has very low potency without a progestin, but that would be the only scenario other than when someone does not have ovaries. Sorry, rather, when someone does not have a uterus. And then just going through how we think about risk versus benefits. So it's a balancing act, and most of the data we have about risk versus benefits is balancing the risk of use of the medication against the risk of pregnancy, since most of the data that we have is based on using the medication as a contraceptive. And so we don't really have good tables out there assessing risk of worsening acne compared to risk of estrogen, for example. So we have to balance the improvement in quality of life, the improvement in health, and the overall general benefits that we see from the medication versus the risks. And this is a shared decision-making concept that sometimes requires a fair amount of discussion with the patient. The CDC provides medical eligibility categories related to contraception only. And they range from category 1 to 4, 1 being a condition for which there's no restriction, 2 being a condition for which the advantages of using the method generally outweigh the theoretical or proven risks, and then 3 and 4, which are generally do not use in most situations. In my work in high-risk contraception, we might be using category 3 or 4 sometimes, but generally people who rarely prescribe contraceptives would only be limited to prescribing for category 1 and sometimes category 2. And this data is available both in these easy to use charts as well as online. And there's also an app, and we'll go through some of the specific things that are present in the app as well. Some of the category 4 medical conditions are as follows. There are quite a few of them. Many of them really just come down to there being a complex patient who with a higher risk of VTE. But some of them are other things you might not have thought about, such as prolonged immobilization or being immediately postpartum. I'm going to turn it over now to Dr. Samuelson Bannow to go through some of the other considerations.
Thank you very much, Dr. Baldwin. All right, so as Dr. Baldwin said, I'm going to talk a little bit about risk, really narrowing in on VTE moving forward in this talk. So risk of VTE with some of these different methods and formulations. So always super important to frame this conversation in terms of what is the increase in risk compared to background and what is the background risk itself. So in this population, in folks who are eligible for hormonal contraception, the background risk of VTE is very low. It's 20 to 40 per 100,000 person years. And so this is important to keep in mind, even when we're talking about doubling risk, as we often talk about in these scenarios, we're still in a relatively low risk overall, which is important to frame the conversation. And you know, the highest risk here with patches, 40 to 100%, it's very wide. Even more important to keep in mind is the risk of what we're trying to prevent, which is pregnancy. So pregnancy itself can obviously increases the risk of VTE considerably. So the rate of VTE events in pregnant folks is 50 to 200 per 100,000 pregnancies. So considerably higher than the risk of these medications. All right, sorry, I went a little bit too far forward. So what about the risk between different formulations? And so really, Dr. Baldwin set the stage for this beautifully, talking about the estrogen component and the progesterone component. And so here, this is a nice little kind of forest plot that broke it down by second and third generation combined hormonal contraceptives, and then over here is the quote-unquote fourth generation drospirenone based, the Yaz or the Yasmin that we've all heard a million lawyer advertisements about. I think the really helpful thing to keep in mind here is this little outlier at the top with the very highest risk. That is with 50 micrograms of estrogen, which we do not do anymore in general, at least not for regular contraception. And so the estrogen really is the main driver. And then, as Dr. Baldwin alluded to, there are interactions with different forms and doses of progesterone. So in general, levonorgestrel, as the progestin component, slightly lower risk than gestadine, desogestrel, and then drospirenone. So there are nuances here. In clinical practice, I don't think that this really comes up super often. I think there are other nuances to consider, but it's helpful to be informed and when you're thinking about the overall impact of these medications on risk of VTE. And this meta-analysis is getting a little bit old now, but I still love it because it really, I think, highlights the differences, the nuances between different forms of progestin-only contraception. We've already talked about the risk with estrogen. What about the risk with progestin only? And this really highlights the fact that DMPA, dipomedroxyprogesterone, is the only progestin-only contraceptive that is really and truly associated with an increased risk of VTE, really approaching that of combined hormonal contraceptives, as you can see here. So in our practice, we generally avoid dipomedroxyprogesterone if we're choosing a progestin-only contraception based on a super high risk of VTE. Again, there's a lot of nuance here, a lot of things to consider, but the other progestin-only methods are certainly lower risk. And so IUDs, everybody's favorite Mirena IUD. I love it. You love it. It's great stuff. The risk is really low. And in fact, some of these, the risk actually, falls on the left side, a decreased risk of VTE. Now, does that actually decrease the risk of VTE, compared to somebody not taking it and not pregnant? Probably not. But certainly if you're reducing things like episodes of acute heavy menstrual bleeding, requiring hospitalization, pregnancies, things like that, overall, it's certainly safe is what we can say. The data around the implant can get a little bit confusing. There's a lot of different opinions around it. People will refer a lot to one study where there was a numerically increased risk, but there was about 1.4, but it did not cross, or it did cross 1. So not a statistically significant increased risk. And again, putting it in context of all these other things, risk of pregnancy, risk of, uncontrolled menstrual bleeding, things like that. We have to keep all these things in mind. Progestin-only pills, oops, sorry, I did it again. Progestin-only pills, again, we generally consider these to be safe. There is this one little outlier here that falls on increased risk of VTE, and I'll point out that that's therapeutic. I think there were probably some other issues with that study, but progestin-only pills in general are quite safe from a VTE risk. We also have to keep in mind all the other concerns like efficacy and things like that. I will note that drospirenone only is not included in this diagram because it wasn't out yet as a sole therapy at the time of this publication, and hopefully we'll get more information on that in the future. We don't really have a lot of data on that so far in terms of VTE risk, but the gestalt is, I think most of us think it's going to be fairly low risk, and again, certainly lower than the risk of pregnancy. So that's the first limitation of the data, as I mentioned. There's also a lot of lumping. You saw different formulations of progestin-only pills. One of the diagrams included implants and progestin-only pills together. I think there's a lot of information that we don't necessarily have. There's a lot of variables that are yet unknown, but I think the general principles of non-DMPA progestin-only methods being safer from a VTE risk holds, and I think that will continue to hold in the future. That's helpful information to keep in mind. So now let's talk about hormonal therapies in high-risk conditions. And again, Dr. Baldwin already alluded to this with her reference to the CDC MEC criteria. And here we focused in on the deep venous thrombosis section of that. And so they address a number of different scenarios, including history of DVT or PE, not receiving anticoagulant therapy, acute DVT or PE, DVT and PE on established anticoagulant therapy for at least 3 months, family history, major surgery, minor surgery without immobilization in terms of risk factors of VTE. And ultimately, there's a lot more nuance and differentiation on this part of the chart than on the actual recommendations. In most of these scenarios, the CDC did come down and say that the risk is going to outweigh the benefit for combined hormonal contraceptives. I think there's some nuance here, in terms of consideration. So we don't have great data on, DVT and PE established anticoagulant therapy for at least 3 months in terms of we don't have randomized controlled trials, but we certainly do have post hoc data. I think, so I personally don't feel the need to take folks off of their CHCs immediately when they get diagnosed with a VT, as long as they're on anticoagulation, and we'll talk a little bit more about that later. I have a little bit of a bone to pick with a recommendation for copper IUD. Anybody who is in that space is going to know how much bleeding it causes, but that's sort of my personal experience and opinion. In general, though, all of these progestin-only methods are considered by the CDC to be preferable and safe compared to CHCs. Here we go. So things to keep in mind in the setting of acute VTE, as I mentioned, discontinuing those combined hormonal contraceptives may impact heavy bleeding. So if you think about the fact, this scenario that we've all seen a million times, right? Person comes in, they're on combined hormonal contraceptives, they're diagnosed with a DVT or a PE, they're in the ED, They get started probably on rivaroxaban, and their CHCs get stopped because everybody knows that CHCs cause clots, and people with clots shouldn't be on CHCs. But then you sort of create a double problem there, right? You're inducing a withdrawal bleed that may be a severe bleed, particularly if somebody was using continuous or scheduled CHCs to control their heavy menstrual bleeding, and you're adding an anticoagulant on top of that. So that's a potential risk with discontinuing. Additionally, we don't really ideally want folks to become pregnant within the first 3 months after they have the VTE event. There's no data on that, but it is expert opinion. And I'm not referring to myself as the expert there, although I agree with that. I'm referring to other experts. So I think it's a particularly dangerous time to withdraw contraception. So we worry about that as well. And so in somebody who has an acute VTE event, the recommendation is usually to try to get them switched to or started on a progestin method, as soon as possible, at least within the next 3 months. But I don't think that you necessarily have to stop your combined hormonal contraceptives. I think we do more harm than good, especially there are some data out there that show increased risk of recurrent VTE with folks who have heavy menstrual bleeding, specifically on rivaroxaban. So again, a lot of nuance here, a lot of things to keep in mind. So what about history of VTE or arterial thrombosis that's not acute? So again, heavy menstrual bleeding is a very common problem in anticoagulative folks. 70% of oral anticoagulant users who are menstruating will have heavy menstrual bleeding while they're anticoagulated, which is just astronomical. You consider about 30% baseline, which is already much higher than it should be. That's a different discussion for a different day. In this population, in my care of this population, I make sure that I'm monitoring for iron deficiency. I check a ferritin personally at the time of diagnosis, or however, whenever they come to me in clinic. I usually then do it every 3 months if they've been iron deficient. And then if somebody does really well, if you're controlling their menses, with Mirena or something else, it may ultimately not be an issue, but you do need to be on top of that up front, especially when they're adjusting to the impact of anticoagulation on their menses. I always consider evaluation for need for menstrual management. I'm fortunate I see patients in a combined clinic with colleagues of Dr. Baldwin's, and so we can talk about both at once. But it's important to have this conversation, talk about menstrual management, and talk about contraception when we're seeing people with the potential to become pregnant who have had an acute VTE event. And that's something that often gets completely forgotten and disregarded in the conversation, which is unfortunate. I also provide counseling for future VTE risk with estrogens. We need to establish whether an event is provoked or unprovoked. Obviously, there's different implications for that. And I always create a plan for use of estrogen in the future. And so I talk not only about, CHCs, pregnancy, but I also talk about the use of HRT in the menopausal setting, which a lot of my 20-year-old patients laugh at me about. But the reality is probably nobody is going to talk to them about that again. And so I think it's important to discuss the nuances of what the options are, which we'll talk a little bit more about in subsequent slides. Also very important to remember that the risk of recurrent VTE is higher with the next pregnancy. So contraception, folks need to be on good contraception, ideally with progestin. Fortunately, our LARC methods are progestin-based, which is awesome. It's also important to remember, if you have somebody on warfarin for whatever reason, that's teratogenic. That's another reason to caution them around pregnancy. And it's really important to make sure that we're doing preconception counseling, if not at the time of establishing care, reminding the patient to come back and be seen, ideally before they start trying to become pregnant. So we can discuss things like if they're on anticoagulation at baseline, when do we transition to low molecular weight heparin? If they're not and they had an estrogen-provoked DVT or PE, talk about getting them started on low molecular weight heparin in the setting of pregnancy. So again, this entire slide I feel like is missed in probably 80% of the cases of acute thrombosis in this population, but it's absolutely critical. All right, off my soapbox for a moment here. So let's thinking about, inherited thrombophilias and synthetic estrogen. As Dr. Baldwin alluded to, the risks are different with synthetic estrogen. And so, with folks, when folks have a personal history of VTE, we avoid estrogen. That's pretty straightforward. We prefer progestin-only methods, unless they could potentially be on anticoagulation, and that is a conversation that comes up sometimes in specific settings. For example, endometriosis that can only be symptomatically managed with estrogen. I do have that conversation with patients. Folks with family history as their risk factor. So in general, we still prefer progestin-only methods in people with a first-degree relative, really regardless of testing. I think testing can be harmful, both because it can make people more scared than they should be, but it also can provide false reassurance. So even if somebody tests negative for all the thrombophilias that we know of and have tests for, if they have a first-degree relative, they're still at high risk, and we still want to be prioritizing progestin only over estrogen-based contraception. Importantly, routine screening for thrombophilias is not appropriate, and that is one thing that all guidelines agree on, is that we should not be screening the general population for thrombophilias before we start them on CHCs. So in most cases, both folks at risk for VTE, both synthetic estrogens and confirmatory testing should be avoided. And so to talk a little bit about the HRT issue that I mentioned earlier, so hormone replacement therapy in menopause. This is from the position statement of the North American Menopause Society. And I love this chart because it really, I think, visually depicts not only the risks, but also the benefits of these methods. And so the benefits are here below the line and they're in blue. The potential risks are above the line and in red. And this little dotted line, anything below that dotted line is really considered to be rare. And as you can see, they had two different data sets here. So one from conjugated equine estrogen only, one with conjugated equine estrogen plus MPA, which is medroxyprogesterone acetate. And you can see in general, there's a lot of benefits, particularly with the estrogen only, and relatively few downsides. Now, their position statement, they do go on to recommend the lowest dose needed, and they also recommend using the transdermal route instead of the oral route, because that is much safer from a VTE risk standpoint, which is helpful information to keep in mind in a variety of settings, including risks of feminizing hormone therapy. Because again, as we've been discussing, the oral estrogen really does increase the risk, even in this patient population that is typically of male sex, taking feminizing hormone therapy. Additional factors include age over 40, smoking, sedentary obesity, underlying thrombophilic disorder, and it can be further increased with the use of third-generation progestins. So in this population, when they're at risk of VTE, we really prefer the transdermal route of administration, again, which I think is a much safer option. And that is what I counsel my patients on. When I'm having that conversation with them, they've had a clot on estrogen, and I'm talking to them about having potential estrogen-containing therapies in the future. What we really talk about is that the transdermal route is safer and preferred. So other high-risk conditions to think about, there's a number of them, again, highlighting that we need to be keeping in mind the risk for pregnancy. As I commonly say in our hematology meetings, the alternative to contraception isn't nothing, it is pregnancy. And I think particularly in the hematology world, we often forget that. We think, oh, we're just going to take away the risk factor, and we don't think about the subsequent risk of pregnancy. Specific conditions we like to think about, so obesity, 2 to 3-fold increased risk of VTE at baseline, increases to 10-fold with estrogens. Additionally, some contraceptives are less effective in a population of obese individuals because there's reduced levels of circulating hormones. And so this is a population we might want to favor progestin-only non-DMPA methods in. Sickle cell disease always involves an individualized approach. Keep in mind that this patient population is also at risk for arterial thrombosis. Again, a situation where progestin is going to be our first line option, but all of the factors have to be kept in mind, and it really needs to be a shared decision-making process. And autoimmune disease in general, estrogens are okay. Antiphospholipid syndrome being sort of a unique scenario. And if patients are anticoagulated, Again, the MEC might disagree if they've had a history, or the CDC MEC might disagree if they've had a personal history of clot. But in our practice, we find that sometimes the benefits outweigh the risk in anticoagulated patients, and I think the risk of recurrence for them is quite low. So our conclusions. So always consider risk versus benefit. If uncertain risk, choose a progestin without estrogen. Consider family history and personal history, different risk factors, or different degrees of risk there. Avoid testing for thrombophilia without a personal history of VTE, and even sometimes in that case. The type of estrogen and whether in combination matters, and not all hormones carry similar risks. So we are going to be moving on to our question and answer session, but first we're going to repeat these polling questions. All right, so which route of hormonal administration is associated with the highest risk of VTE? Your choices are transdermal, vaginal, sublingual, and oral. So I think we'll be seeing the results here soon. There we go. All right. Yes. Okay. Pretty much everybody got this. I don't feel the need to go into too much detail. Oral is absolutely the highest risk. Transdermal and vaginal are a much lower risk. And sublingual we didn't address today. And I have never personally encountered that. I have to ask Maureen if that's a thing. All right. Next one. So for which high-risk medical condition is estrogen not contraindicated? So be careful, we have a double negative here. So basically, in which scenario is it okay to give estrogen, or not, which of these is not a factor that would push you away from estrogen? So options are chronic hypertension, age greater than 45 years old, prior venous thromboembolism, or severe cirrhosis. Again, we'll give everybody a moment to vote. All right, most of us got this right. So age greater than 45 years of age that is correct. It is not a contraindication to estrogen. We like to avoid certainly in prior venous thromboembolisms, severe cirrhosis, and in chronic hypertension as well. We didn't talk about that as much in this talk, but it is correct. Next question here. So what does category 2 mean in the US CDC medical eligibility criteria? So that was the lighter green in the colorful chart we showed. So use estrogen if anticoagulated, use estrogen in all situations, use estrogen since benefit outweighs risk, or if benefit outweighs risk, and use estrogen only if anticoagulated. All right, nice. Well done. Okay, I'm not going to dwell on this. Clearly, we got this. All right. So how does synthetic estrogen potentiate thrombosis? So your options are probably due to upregulation of hepatic enzymes, probably due to CYP450 drug interactions, probably due to genetic polymorphisms, or probably due to binding to progestin receptors. I think the fact that all of these start with probably really nicely encapsulates the fact that this is not something we fully understand. But we'll give everybody a minute to answer. All right, here we go. Most folks got this right. So it is probably due to upregulation of hepatic enzymes. So I see, the probably due to binding to progestin receptors. That's a very tempting alternative because we did talk a lot about how estrogens and progestins both bind to estrogen receptors. But it is the upregulation of hepatic enzymes that we think causes it. All right, next slide, please. All right, which medical society suggests the use of transdermal estrogen for their population, specifically in high-risk health conditions? So we have the World Professional Association of Transgender Health, or the WPA, United States Centers for Disease Control, or CDC, North American Menopause Society, or NAMS, or Society of Family Planning, SFP. All right. So this one, there were actually two potential right answers here. So the one that we talked about in this lecture was the North American Menopause Society, or NAMS, but technically the World Professional Association of Transgender Health does recommend that as well. So I think that is our last question. So we will move on to Q&A.
Thank you, Bethany, for giving out the answers for the polling questions. And thank you, Maureen and Bethany, for the fantastic presentation on a very important topic. So we will now move on to the Q&A session. As the questions are coming in from the attendees, why don't I ask you both, some of my own questions. I think it's a fantastic topic, but as a hematologist, we are always confused about the different types of progesterones and the estrogens and the combinations. I think the manuscript and also during your presentation, you beautifully explained how certain progestins have a higher risk of thrombosis, like the DMPA, for example. But I'm also personally very intrigued about the implant, the etonogestrel implant, because I believe the product insert carries a warning. Can you just go into the details of that? I mean, can we recommend the use of implant in patients who carry a risk for thrombosis or not? And how would you justify that?
I can start this off by just making sure that it's clear that the way the FDA looks at all of the hormone therapies for contraception is as an entire class, and it does not consider whether they are progestin only versus combination. And so every single product in that class has that same warning. And so it's for us to interpret that based on pharmacokinetics.
All right, thank you. I have one other question for Bethany. We know that, there's not a whole lot of information, but with limited information that is available, sickle cell disease is considered probably a higher risk for thromboembolism. So in a patient with sickle cell disease, when you want to place them on hormonal contraception, or when your gynecology colleague is thinking about that, would you recommend thrombophilia testing in those patients prior to hormonal therapy, especially the hormonal therapeutic options, which can carry a higher risk for thromboembolism?
Yeah, that's a great question. I personally do not recommend that. And the reason is I think it's safest to approach sickle cell as if it is a thrombophilia. And we are already recommending progestin-only therapies as the first line. And so in that setting, I don't think the thrombophilia testing is going to change that. I'm not going to say, oh, yes, it's really fine to give estrogen, or estrogen can be first line in somebody with sickle cell disease, regardless of their thrombophilia testing. Again, there's a place for it, taking everything into consideration, but I don't think that the thrombophilia testing is the key factor there.
Yeah, certainly. I think there's a lot more data that needs to come through and a lot more research to happen in that area. We have some interesting questions coming from the attendees, so let me start with the first one. That is, could you comment on the use of these hormonal therapeutic agents or hormonal options in women and girls with inherited bleeding disorders, like female carriers of hemophilia or von Willebrand disease? Does Bethany want to answer that question?
I am so sorry. I thought you were. I'm so sorry. I thought you were talking to Maureen. Can you repeat that question for me?
The question is, how do you recommend the use of these hormonal options in patients with inherited bleeding disorders, like
yes.
female carriers of hemophilia or von Willebrand disease?
Yes, absolutely. So we tend to use Mirena a lot in our practice just because it is extremely effective for controlling bleeding. But I think, really, honestly, any method that the patient likes and feels comfortable with, of the things that we talked about today, is going to reduce bleeding overall. The etonogestrel implant, and part of my distraction was I was seeing the question about that in the comments, can cause some irregular bleeding. And so that may not be the best option for folks when we're really thinking about bleeding disorders and heavy menstrual bleeding. But I think, there's a dual benefit to contraception. It can help avoid a risky pregnancy, and it can help control the heavy menstrual bleeding. So we try to get these folks in with their gyne colleagues to really talk about the full armamentarium of therapeutics, including Mirena.
Excellent. Thank you. There's another very interesting question from the attendees. And I actually have a very similar question, so I'll tie in both together. And I think this may be for Maureen, I guess. How do you modify considerations for DVT and PE risk in our youngest, newly menarchal and adolescent patients? And so, Maureen, I think when you presented also, you clearly mentioned that the US CDC, MEC medical eligibility criteria categories are for contraceptive use of hormonal therapies. So when we utilize hormonal treatment for adolescent females, for example, for menstrual management, heavy menstrual bleeding management, can we extrapolate and apply these same criteria, or do you have to modify this? What do you think?
Yeah, this is a really good question. Thank you, Nicole, for the question. I think that it's first of all most important to just make sure that the patient is having a good entry into their experience with management. And so it's most important to find a medication that results in the most desired bleeding pattern, in my experience. And then we have a good amount of data about safety of use of both estrogen and progestins in younger menarchal patients. And so I also reassure the family about that data. But I do actually tend to avoid estrogen in really any patient unless I feel like it would be beneficial in some way. So it can be most beneficial in making sure they have less irregular or breakthrough bleeding. But many younger patients on even just a 0.35 milligram norethindrone pill will have regular periods without unexpected bleeding. And so I first try that to see if they can achieve menstrual management to their goals. So I hope that answers the question.
Okay, that sounds good. Thank you. And here's an excellent question. Don't we all love this question? Can you speak about the use of antifibrinolytic agents in patients who are on combined hormonal therapy, specifically in patients with underlying bleeding disorder and I guess maybe having heavy menstrual bleeding already? What are your thoughts?
That was the other part of my distraction because I really wanted to answer that question. The way I think about this is how many patients with bleeding disorders do I put on tranexamic acid in the postpartum setting? And the answer is almost all of them. And if you remember that slide at the very beginning about the baseline risk, the risk of VTE with combined hormonal contraceptives versus pregnancy. We know the risk with pregnancy is higher, particularly in the postpartum setting. And we have wonderful data from the woman trial and other trials showing that the risk of VTE is not increased with the use of antifibrinolytics in that setting. And so I think that black box warning based entirely on a theoretical and repeatedly unproven concern is a bunch of it's not correct. Let me put it that way. And so I frequently counsel patients. I do put them. We try one therapy at a time first. I think that's always a rational thing to do. But if patients need combined therapies, we do it. And I will counsel patients on how to discuss with their pharmacists because some pharmacists will refuse to dispense and it can be problematic. And so I review the patient with the data to equip them before they go. And I tell them to come back to me and let me know, and we'll find a different pharmacy or do something if we have to. I think it's a really unfortunate barrier to care that has been put in place by that black box warning for no really proven reason.
All right. Thank you for those great questions coming from the attendees and for addressing those questions so beautifully, and also for your excellent presentation, Dr. Baldwin and Dr. Bethany Samuelson Bannow. So that brings us to the end of today's presentations. If you have any other additional questions, we'll be happy to address them via emails later with responses directly to you. Before we conclude the session, I just want to make an announcement here on behalf of the Foundation for Women and Girls with Blood Disorders and my fellow conference planning committee members. We would like to invite you all to attend our biennial conference, which is going to take place from September 13th to 15th in Long Beach, California. Registration is now open and can be found on the link, and I believe the link is being posted in the chat box, or it can be sent to you as well, or you can find the link in the FWGBD website. The foundation is very pleased to provide this program at no cost to all attendees. Participants will receive the evaluation following this program in your registration email shortly, along with the link to claim your continuing education certificate as well. A recording will be made available by the end of the week, so all registrants will be informed about this as well once this is available. Thank you very much for your attendance today. Please join us for our future programs. We have many exciting programs throughout the year, and you can get all those details at our website at fwgbd.org. Thank you, everyone. Bye-bye.